glomerulonephritis and nephrosis, also called nephrotic syndrome. Not a big topic on the NCLEX or exit exams, but it may come up on your nursing exams. So anytime you see the word neph, think kidney, and itis, think inflammation. So glomerulonephritis is inflammation and scarring of the kidney, specifically inside the glomeruli, the little washing machine bubble inside the kidney. Now this inflammation sort of stretches out and destroys our little glomeruli, causing increased permeability, kind of like poking holes in a coffee filter. Since the kidney acts like a filter, instead of filtering protein, well, now it leaks out. Now on the other side, for nephrotic syndrome, also called nephrosis, the key difference is we get high, massive amounts of protein being dumped into the urine. And for glomerulonephritis, we get those low, mild amounts of granular proteins. Now in terms of the causes, nephrosis is caused by autoimmune diseases like lupus, where the body attacks itself, hurting the kidneys, triggered by the 4 S's that initiate an immune response. And this goes nearly for all autoimmune diseases. So we have stress, sickness or sepsis, basically infection, S for smoking, and then the last S is for sun or hot temperatures. And on the other side, glomerulonephritis is different in that it's caused by an infection, typically a strep infection like strep throat, that travels to the kidneys and resolves by itself within 14 days once the infection is gone. So we get the same sort of inflammation, but just from different causes. Now the big key point to write down here is that nephrotic syndrome, as mentioned before, we have big protein loss in the urine. So the UA will show high proteinuria, and blood labs will show low albumin, that hypoalbuminemia. So the memory trick for nephrotic syndrome, just think Nerf balls of protein. Remember those toys you used to play with as a kid? So just think of a bunch of Nerf balls of protein being dumped from the body and into the potty. Now that was the most tested clinical manifestation on most exams. Now for a little side note here, this part is not really a big focus on the NCLEX, but maybe on your exams. So other manifestations, we have edema that is present with high permeability of the kidneys, a high risk for clots in the body like a DVT or a PE, and this results because as protein is lost, a special protein that helps thin the blood is also lost. It's actually the same protein that heparin uses in order to be effective in thinning the blood. So when this is gone, it leads to blood clot risk all over the body. Now lastly, hyperlipidemia, those high lipids in the blood, result as the liver tries to compensate for all that low albumin. But again, it's not a need to know for the NCLEX, it usually just focuses on the protein. Now on the other side, for glomerulonephritis, we have less protein being dumped. So the UA will show lower proteinuria. And since it's caused by an infection, the key assessment findings will see recent strep infection, fever, as well as blood labs will have high WBCs, since the body is typically fighting that infection. Now for both conditions, the 2 kidney labs will be increased. So the key terms, creatinine over 1.3 means bad kidney, and BUN over 20. And lastly, as a general rule, urine output 30 mLs per hour or less typically means the kidneys are in distress. Now, since the kidneys are inflamed here, we get fluid retention and classic fluid volume overload signs and symptoms, ending up with a high blood pressure, edema, JVD, and crackles in the lungs, that fluid in the lungs. Now, this results in deadly complication with renal failure and hypertension crisis. We're talking BP so high that the client can have a bursted blood vessel inside the brain, known as a stroke, or aka a CVA. So we must report these key signs, write these down. A headache and mental status changes, as well as nausea and vomiting. These 2 are the most classic signs for hypertension crisis. And lastly, oliguria, that no or low urine output, as well as new, sudden, or rapid weight gain. We must teach the client to report any of these signs to the provider immediately. Now, as far as treatments for nephrotic syndrome, we treat the causes by removing the trigger and helping the body to stop attacking itself. And we treat the inflammation and swelling. So we give steroids to soothe and stop the swelling to heal those kidneys so that protein doesn't leak out. Now, steroids ending in zone like prednisone. So just think zones treat the swelling. Now watch out for the double S's of zones. They increase sugar and increase the risk for sepsis, basically that infection. Now the diet here, this is the key difference. Be sure to write this down. In nephrotic syndrome, we increase protein. Big NCLEX tip. Since the key sign here is that massive Nerf balls of protein with nephrotic syndrome. This is the only kidney disease where we actually increase protein. So write that down. All the other kidney conditions, we limit protein. Now for glomerulonephritis, we treat the cause of infection by giving antibiotics, and the big key term here is to educate the client to finish all the antibiotics. And the big key difference again in diet, we limit protein. Big NCLEX tip there. Now lastly, for both conditions, we want to rest the kidneys and give them a day off. They're hurting and they're inflamed. So we do this by decreasing the blood pressure to take the workload and pressure off of them. So for diet, we want to lower fluids and lower sodium, that sodium restriction. So just think, sodium swells the body with fluid, increasing the blood pressure. And for medications, are antihypertensives to decrease the blood pressure. Mainly we use the A's and the D's on our chart here. So A is for ACEs and ARBs. ACEs end in pril like lisinopril, and ARBs end in sartan like losartan. And as far as our diuretics, these end in ide, so think the body is dried. So for loops, we have furosemide, and thiazides, we have hydrochlorothiazide. Now both of these guys are potassium wasters, so watch out for hypokalemia, that low potassium below 3.5. All right, guys, that wraps it up for this segment. Don't forget to take your quiz. Okay, now for the practice questions. Question 1. The nurse is assessing a client diagnosed with nephrotic syndrome. Which findings should be reported to the provider immediately? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break this question down following the question breakdown strategy. So first, we look at the key terms inside the question. So this question states nephrotic syndrome, and the question's asking findings to be reported to the provider immediately. So obviously it's a priority-based question. So we must think loss of life or loss of limb here. Now, the second thing we do is we think of a few things about those key terms. So nephrotic syndrome, you think of Nerf ball-sized protein inside the urine here, with that huge risk for hypertension crisis and blood clots all over the body. So option A, a severe headache with new mental status changes. Yes, the key term here is severe headache, with another big key term, new mental status changes. So the big key terms for hypertension crisis is that severe headache that can lead to CVA stroke, basically a blood clot in the brain or even a burst blood vessel known as an aneurysm. Now B is incorrect. Proteinuria is noted on urinalysis and creatinine of 1.2. Now, this won't kill the client because we expect protein inside the urine, and creatinine of 1.2 is borderline bad. Remember, over 1.3 means a bad kidney. So this doesn't need to be reported immediately. Now C, a frothy tea-colored urine. No, this is to be expected, so it's incorrect. And option D is also incorrect. Elevated serum lipid levels. This is likely, but not really an immediate priority. So it's incorrect. Option A would be the most correct here. Now moving on to question 2. The nurse is conducting teaching on glomerulonephritis. Which key point does the nurse include? So pause the screen and try your best to answer this question. You got 60 seconds. All right, let's break it down following the question breakdown strategy. So first, we always look at the key terms in the question. Glomerulonephritis, and the question is asking for what key point to include. So next, we think about a few things you know about those key terms. Now with glomerulonephritis, we have very little globs of protein inside the urine. So we have lower proteinuria. Now, it's typically caused by a recent strep throat infection that has traveled to the kidneys. Okay, now it's time to look at the options. So, option A. The pathophysiology of glomerulonephritis is associated with congestive heart failure. What? No, this is totally incorrect. It is not caused by CHF. It is typically caused after a strep infection. So remember, HF for heart failure, the heart fails to pump blood forward. So clients end up with HF, heavy fluid inside the body. Now B, the nurse should monitor for massive proteinuria and edema in clients with glomerulonephritis. Now, no, this is typical for nephrotic syndrome. Remember, glomerulonephritis, we have very little globs of protein in the urine. Now, moving on to option C, the client should be assessed very closely for signs of fluid volume deficit. No, it's actually the opposite here. So think about it. The kidneys are damaged, so fluid can't get from the body and into the potty. So naturally, clients fill up with fluid. Now, lastly, option D. The most classic manifestations are lower proteinuria, that's true, and a fever as it typically presents after a strep infection. Yes, all the key terms here are correct. Lower protein and fever because of that streptococcal infection. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz. Now for polycystic kidney disease, also called PKD. This is an inherited disorder in which clusters of cysts, which are non-cancerous round sacs containing fluid, develop within the body, but mainly the kidneys, causing enlarged kidneys and eventually chronic renal failure, where clients have a loss of kidney function over time. So let the name help you here. Poly means many, cystic means cysts, kidney disease means, well, kidney disease. So put it together, a disease with many cysts within the kidneys. Now the causes, it's mainly genetics with abnormal genes that runs in the family. So a few key terms that you should write down. Autosomal dominant as well as gene 15. And in terms of diagnostics, a CT scan can be done as well as abdominal MRI to visualize the kidneys. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz. Kidney stones, also called renal calculi. So let the name help you here. Hard calcified stones inside the renal, or names with lith, meaning stone. So urolithiasis means a stone in the urinary system, renal lithiasis, a stone in the renals, and ureterolithiasis means a stone in the ureters, basically those tubes that connect the kidneys and the bladder. Now, stones are typically made of calcium or other waste products in the urine, like uric acid or protein. Now, for the risk factors, men have a higher risk for getting those kidney stones, typically due to dehydration. So just think of old men drinking coffee and not enough water, as well as urinary retention from BPH, that big prostate. So the memory trick we use is BPH. Just think of a big prostate that holds back urine. Now for the signs and symptoms, write this one down. Extreme pain is critical. It's like a knife in the back. They even say it's equivalent to giving childbirth. Now we also see sweating, nausea, vomiting, as well as a rapid heart rate and breathing. But the priority here is the pain. So Kaplan states that a priority intervention for urinary calculi with right flank pain is to, number 1, relieve the pain. So we give meds to relieve that pain. Now, as the stone moves down the ureters, it sort of stretches and scrapes the tube, causing blood and more pain. So the urinary analysis will see hematuria, which is a big NCLEX tip, basically blood in the urine. So RBCs will be present in the urine analysis. And we strain all the urine to catch stones and analyze it. Now for procedures, we always start with the least invasive first. So we use shockwave lithotripsy, which is basically shock waves to break up large stones that are stuck inside the kidney, breaking them up into smaller stones so they can be easily passed. Now in terms of education, after the procedure, write this down. Increase fluids to help flush the stones from the body to the potty. And normal expected findings after the procedure is bruising and pain on the procedure site, usually in the flank area on the back and side, and blood in the urine is normal up to 24 hours after the procedure. No need to report. Now the key here is not normal is fever or chills. This is definitely indication of infection, so you must teach that patient to contact the provider immediately. Now ATI mentions expected findings after a lithotripsy, and the answer is stone fragments inside the urine, completely normal. Now if the stones are too big and the shock waves don't work to break up that stone, then we go more invasive and cut that patient open. Surgical removal of the stones include a percutaneous nephrolithotripsy, also called a nephrolithotomy. We basically stick a needle and scope into the renal pelvis to break up and suck out those big stones. Now after the procedure, a temporary nephrostomy tube and bag is in place, and this allows any loose stone fragments to pass. So an expected finding is to find these little loose stones inside the bottom of the bag. But the bad news here is that the drainage tube can get clogged with these stone fragments. So the key priority, write this down. We need to maintain tube patency. We need to keep that tube unclogged to keep that urine flowing. The worst case scenario is that this little tube has a clog and now urine backs up into this injured kidney recovering from surgery. So write this down. Gentle irrigation of the nephrostomy tube with sterile, normal saline, may be necessary to keep the tube free from clogs. Kind of like a water slide, right? You need to wet it down so those stones can slide around, or basically slide out. Now again, we do this first for any drainage that is stopped completely, since clogged tubes are very serious. The goal here again is to keep that urine flowing. So ATI mentions, teach the patient to report back pain to the provider for the client with a new nephrostomy tube. This can indicate clogging or even infection. Now, in terms of treatment, we treat the pain and flush the stones. So number 1, we administer analgesics for the pain. And number 2, we flush the stones with a lot of fluid intake, about 3 liters per day, to dilute the blood and flush those stones, as well as decrease the risk for a urinary tract infection. We also strain all the urine for stones, and we use ambulation to walk and move around to facilitate passage or movement of those stones. Remember, not bed rest. Write these 2 things down. Not bed rest, and never massage the flank pain. This can cause more damage to the kidney area. Those are the 2 big no-nos that every exam loves to test on. Now for diet, we eliminate the cause of the stone. So restrict protein, those animal meats, and we limit purines. So red meats, organ meats, and even beer. Hesse even touched on this, saying that urolithiasis teaching, we restrict, key term, animal protein. All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides. Now for renal failure. We're covering acute versus chronic. So for chronic kidney failure, also called chronic kidney disease, or just CKD, this is long-term chronic damage to the kidneys. We're talking over years and years of destruction, typically resulting in permanent damage. And acute kidney failure, also called acute kidney injury, is that sudden short-term loss of kidney function, but if not stopped or reversed, it can lead to chronic renal failure. So a Kaplan question asks about acute kidney injury. What is the correct understanding? And the answer is sudden loss of kidney function due to loss of renal system circulation or glomerular or tubular damage. So what's really going on in the body? For pathophysiology and causes, let's cover the acute kidney failure first. In acute kidney failure, it can result from 3 types. We have pre-renal, that decrease blood flow to the kidney. So the memory trick we use is think of decreasing of pre-fusion with pre-renal. And then next is intrarenal, that damage inside the renal. Think in the renal for intrarenal. And if the cause is after the renal, that's post-renal. So just think post for past renal. Now let's dig into the specifics here. So for pre-renal, just think of that decreased perfusion for pre-renal. Oxygen-rich blood flow can't get to the kidneys. This decreased blood flow means decreased oxygen. So remember, oxygen is the money of the body. No money, no honey. No oxygen and the body goes broke and dies. Kind of like the kidney is suffocating to death. Now, this is typically caused by obstruction or vessel occlusion, where we have a blockage of blood flow, which blocks oxygen. Now, this is typically from an emboli or blood clot, or even a tumor that blocks perfusion into the kidneys. Another cause is from low blood pressure, that low perfusion with pre-renal. Like patients with shock, hypovolemia from that major blood loss or volume loss, resulting in dehydration, which results in decreased MAP, that mean arterial pressure. Fancy words for low blood pressure, meaning low perfusion, less than 65 MAP, or mean arterial pressure. Lastly, low cardiac output, we get low perfusion. So just think low cardiac output means low oxygen put out of the heart, resulting in low perfusion to the kidneys. Typically from when the heart can't pump correctly, which decreases blood being pumped out of the heart. So we see this with ECG dysrhythmias, with those funky beats, and even clients in heart failure, which is a little bit tricky, so listen close. Even though we may have high blood pressure with heart failure clients, the big problem is low cardiac output. We get low volume of oxygen-rich blood out of the heart. This results in less perfusion and less oxygen to the kidneys. Next, we have intrarenal, that direct damage inside the kidney itself. Again, think intrarenal for inside the renal. Now, this is far more serious because it's more intense with intrarenal. Now, it's also referred to as ATN, acute tubular necrosis. So just think ATN requires immediate attention. Now, typically it's caused from infections resulting from glomerular nephritis, or even autoimmune diseases like lupus, where the body attacks itself, resulting in nephrotic syndrome, which we cover both in a separate video. But really the most tested top 2 causes for exams, write these down, is CT contrast dye, like with a heart cath. So just remember, contrast kills the kidneys. And even antibiotics ending in mycin, like vancomycin and gentamicin. So just think it's a sin to give a mycin, since it's so damaging to the kidneys. Lastly, untreated infections and even long-term use of NSAIDs like naproxen, ibuprofen, and even ketorolac can cause damage to the kidneys. It's kind of like overloading 2 delicate washing machines with thick cement. We literally clog the kidneys here with these medications, and in result, the creatinine lab value shoots up sky high. So the key number to know is creatinine over 1.3 is bad kidney. And the memory trick we use, just think of the 3 C's. Creatinine is the most critical lab value since it shows clogging of the kidneys. And last but not least, we have post-renal. Just think past the renals. There's a renal blockage after the kidneys, which basically blocks the outflow of urine, so urine can't get out of the kidney itself, causing a lot of pressure, pain, and strain on the renals. Like with clients with renal calculi, aka those kidney stones, or even a tumor, or even BPH, that benign prostatic hyperplasia. We see a big swollen prostate in our older men populations. So just think the memory trick, BPH, as a big prostate that holds back urine, and now we have an outflow problem. As far as assessment findings, these are pretty simple. So remember from our anatomy video, what are the 3 waste products that the kidneys filter? Well, remember we use our acronym HOOK, H-U-C, since the kidneys sort of kind of look like a pirate hook. H is for hydrogen ions, which are very acidic, U is for urea, and C is for creatinine. So the key numbers to know is creatinine over 1.3 is bad kidney, BUN over 20 is very bad, urine output 30 mLs per hour or less means the kidneys are in distress, and metabolic acidosis is pH below 7.35. This is typically due to the retention of all those hydrogen ions, which pushes the body into an acidotic state. Now, Kaplan had a question about this, asking what is the best indicator for good renal function? And the answer is 1,500 milliliters of urine in 24 hours. Remember here, urine output 30 mLs per hour or less means the kidneys are in distress. So 1,500 is very, very good in 24 hours. Now, this next part is not a big focus on the NCLEX, but it may show up on your nursing exams. The 4 phases of acute renal failure. So number 1 is the onset of injury, known as initiation, which is not typically tested. Step number 2 is the oliguric phase. Now, this one is key to know. So just think of the O's in oliguric as O for low urine output, less than 400 mLs in 24 hours. Remember, urine output 30 mLs per hour or less means the kidneys are in distress. So 400 mLs in 24 hours, wow, that is really, really low. And just think very sticky, thick urine, we get specific gravity that is high. So the memory trick we use is if urine is dry, then the specific gravity is high. Now the third phase is the diurese phase, also called the polyuric phase. So just think diurese, D for draining urine, a dramatically high urine output, like 3 to 6 liters per day. The kidneys are basically trying to flush out the problem. So very low liquidy urine with a specific gravity that is low. The last phase is the recovery phase. So just think R for really slow recovery, since it can take up to 1 year to fully recover. And the key numbers are returning to normal during this phase. Now, a HESI scenario asked, oliguric phase of acute renal failure, some key findings. And the answer is anorexia, nausea, vomiting, and, key term here, decreased urinary output. So just think low urinary output with oliguric phase. Now, the treatments are pretty simple here. The main goal is to prevent major kidney damage. And we do this by flushing the kidneys with a fluid bolus, or diuretics. We're basically trying to push the kidneys from oliguric phase into the diuresis phase. So HESI mentions a patient reports a loss of appetite, severe headache and lethargy, and dry mucous membranes with key terms here. Urinary output 300 mLs in 24 hours, that is really, really low. Elevated blood urea nitrogen, that BUN, and serum creatinine. So the answer is to treat with furosemide. Now, if you didn't know, furosemide is a diuretic that pushes the kidneys into the diuresis phase. So just think furosemide ends in ide, so the body is dried from diuresing all that fluid from the body and into the potty. Now, switching gears to chronic kidney disease. This is a gradual loss of kidney function going in stages, kind of like shirt sizes, going from extra small to extra, extra large problems. Now, we have 5 stages of CKD based on the GFR, the glomerular filtration rate, stating how much blood can be washed by the kidneys in each minute, specifically inside these little washing machine bubbles called the glomerulus. Now, key term, write this down, over 90 mLs per minute is considered normal. As you can see here, as the GFR gets less and less, this means the kidneys are in distress. This means that less and less blood is being washed, resulting in the blood filling up with waste and excess fluid and way too many electrolytes. Now, this is no laughing matter because the kidneys are in distress here. But here's the key point. The 5 stages are not really tested on the NCLEX, but it can be on your nursing exams. So really focus on the stages 4 and 5 here, since it means that the end stage of this renal disease is getting really bad. Here the kidneys are failing, basically failing to filter the blood with this low glomerular filtration rate, that low GFR. So stage 4, we have 29 to 15 GFR, and stage 5, this is the worst, 15 or less GFR. This is considered end-stage renal disease. Now, the kidneys are basically dead in this stage. There's no way to bring the kidneys back to life, so we typically have to do a kidney transplant and put our patients on dialysis in the meantime. Now, dialysis is that machine version of the kidneys that are used to wash the blood, which we covered in a separate video. Now let's cover the causes of chronic renal failure. The first cause is older age. Geriatrics typically lose 10% of renal function each decade. Technically, older age just leads to physiological decrease of renal function and not renal failure specifically, but you get the idea here. Now, the most tested causes for chronic renal failure is from long-term years and years of chronic damage. So please write this down. You have to know that uncontrolled diabetes from uncontrolled high sugar is a major cause, as well as uncontrolled hypertension from that uncontrolled high blood pressure, and even unchecked autoimmune diseases where the body attacks the kidney. So to help you paint the picture better here, just think of a patient with diabetes who has uncontrolled hyperglycemia for years. Just think of all this thick, syrupy blood like sugary maple syrup being poured into the body. It's like mud inside the delicate kidneys, specifically inside the delicate glomeruli. What do you think it's going to do to the kidneys here? Do you think it's going to destroy them? Well, yes, it's like thick cement being poured into a delicate washing machine, which eventually kills the kidneys, resulting in renal failure. Or what about a patient with years and years of uncontrolled high blood pressure? Think about all that pressure coming from the heart and just pounding against these poor little blood vessels inside the kidneys, eventually scarring and hardening those glomeruli, leading to less blood flow and resulting in kidney failure. That's why it's so important to educate your clients to control their sugar and high blood pressure. Lastly, other main causes include infection causing glomerulonephritis, acute renal failure that worsens and progresses into chronic kidney disease, and even polycystic kidney disease, where cysts develop inside the kidneys themselves. Hesse mentioned this, asking about polycystic kidney disease, indicating that the client is at risk for end-stage renal disease. Now, whatever the cause, the diagnostics are typically the same here. So, creatinine, our number one kidney lab, remember, over 1.3 means bad kidney. Again, think of the C's. C for creatinine, C for critical lab value. So a key term to know is creatinine clearance test. This measures how much creatinine waste is being cleared from the body and into the body. Specifically, how well the glomerular filtration rate is working to wash the waste out of the blood. The test requires both a urine specimen and a blood specimen in 24 hours. So the key points to write down and to know for your exams is 24-hour collection of all urine in a container. And we put it on ice to keep it cold. And another key point is you discard the first urine specimen when the test begins. Write that down. It's always a test question. Now, don't let the NCLEX trick you here. We do not need a midstream sample or a sterile container. That's mostly used for UTIs when you're checking for bacteria or infection. Now, a Hesse question asks, what's the correct understanding of creatinine clearance test? And the answer is to save all the urine samples in a container for a designated period after discarding the first urine. So you kind of see how those two key points are tied in there. Now, switching gears to signs and symptoms, just think about the patho here. You have broken washer machines, right? So we can't wash the blood from waste or excess electrolytes and even fluid. But most importantly, we can't get fluid out of the body and into the body. This lack of urine output is called oliguria. So remember the O's for low urine output in oliguria. Very, very low urinary output, like less than 400 mLs per day. So Kaplan mentions a patient with chronic kidney disease, oliguria is expected for low urinary output. Another highly tested area is the critical complications. So just think all this excess fluid and electrolytes are trapped inside the body and can cause dangerously high blood pressure from all that fluid volume overload. Now, dangerously high blood pressure can lead to strokes, heart attacks, and even further kidney damage from that high tension on all the organs. So the first priority is to monitor for hypertensive crisis. Now the priority key signs to write down: Huge NCLEX tip here. So number 1 is headache. Number 2 is nausea and vomiting. And number 3, a really big one here, is change in mental status. Now, these 3 are always priority, requiring immediate assessment. Write these down. We saw them on various question banks. For key term, hypertension crisis. You must report these key signs to the HCP provider immediately. Now, clients can also get multiple other signs revolving around fluid volume overload, including crackles in the lungs, those wet fluid-filled lungs, JVD, that jugular vein distension, as well as bounding pulses from that fluid volume excess. But these do not take priority over hypertension crisis, so you must know that for your exams and ultimately the NCLEX. Another sign is anemia, those low RBCs, red blood cells. Since the kidneys release erythropoietin, which is that hormone that stimulates bone marrow to produce red blood cells, which helps carry oxygen around the body. But typically that's expected to know and not tested. Now, what is tested is excess waste and electrolytes in the blood due to these broken washer machines. So for waste, we have hydrogen ions. Just think acid when you see hydrogen ions. We get metabolic acidosis with a pH below, key number here, 7.35, due to the retention of all those hydrogen ions. And we also see urea, since it can't get out of the body and into the potty, which eventually develops into uremic frost, those crystallized urea deposits on the skin. Basically, white frost causing pruritus, that itchy skin. But again, these are normal and to be expected, and not priority over hypertension crisis. Remember, those headaches, nausea and vomiting, and change in mental status are all priority here, so don't get it twisted. Now for the electrolyte values, these are always exam favorites, so be sure to write these down. Sodium is high, over 145. Just think high sodium, we get high swelling, which can lead to hypertension crisis. Phosphorus is high, over 4.5, which leads to decreases in our calcium, leading to osteoporosis, those porous, weak bones, making a huge risk for fractures. Now, the big critical one here is potassium that is high, over 5.0. Now, this is the most important number 1 electrolyte on the NCLEX and nursing exams since it pumps the heart. So the memory trick we use is the 3 Ps. Just think P for potassium is P priority since it pumps the heart muscles. So with high potassium over 5.0, we get high pumps of the heart, resulting in peak T waves and ST elevations from high pumps. So key terms to know. Peak T waves happens when potassium is 6 to 7 microequivalents per liter. ST elevation happens when potassium is between 7 to 8. And wide QRS complexes is a late sign, over 8. Basically, the heart is cramping up from too much potassium. Too much high pumps makes a very tight heart that is just basically cramping all up. You have to think that the heart's a muscle, right? So, do you really think the heart can pump normal if this muscle is cramping? Well, no. So this leads to bradycardia, that low heart rate, since the heart is too tight and can't beat correctly, and which ultimately results in weakness, fatigue, and lethargy from less cardiac output, meaning less oxygen out of the heart into the body. And then finally leading to deadly ventricular dysrhythmias like VTach and VFib, that ventricular tachycardia and ventricular fibrillation. If not treated immediately, this will cause death by cardiac arrest, basically that stopped heart. So that's why potassium is priority on the NCLEX and nursing exams, since it pumps those heart muscles. Now, Kaplan had a scenario asking a client with kidney disease is very weak, lethargic, and bradycardic, asking for a suspected finding for this patient. So the key term here is kidney disease, that is weak, lethargic, and bradycardic, that low heart rate. So you have to automatically prioritize and think about potassium here. So potassium 8.5 is the lab value to to be suspected. Now, in terms of treatments, the long-term solution is to wash the blood with dialysis, but this can take some time to set up. So the immediate priority solution and treatment is to lower the potassium and protect the heart from deadly dysrhythmias. We do this with drugs in a very specific order. So write this down for priority treatment. Number 1 is IV calcium gluconate. For the key term, write this down, dysrhythmias. Just think gluconates helps to glue down those crazy heart muscles, preventing deadly dysrhythmias, like wide QRS complexes, which will eventually progress into deadly VTach and VFib. We must glue down those heart muscles with calcium gluconate. Now, if the key term of dysrhythmias is not involved in the question, then we progress to number 2, which is IV 50% dextrose and regular insulin. This helps to lower the potassium. So just think insulin puts sugar and potassium into the cell, out of the blood and into the cell, which lowers blood serum potassium. Most effective way to lower blood potassium very quickly. But insulin also lowers blood glucose too, basically that blood sugar. So that's why we also give dextrose to help prevent that low blood sugar, that hypoglycemia. Now, don't let the NCLEX trick you here. What if the key term dysrhythmias is not in the question? Well, then we progress to option 2, which is just to give the IV dextrose and insulin first to lower that high potassium. And lastly, 3 and 4, we can also give K-exolate, that polystyrene sulfonate, as well as dialysis. But again, these typically take longer to lower potassium, so that's why we put them last here on the list, because they take a longer time. Now for the top 2 missed NCLEX questions. So question number 1, a patient with chronic kidney disease missed 3 dialysis sessions. With key terms here, potassium level of 8.1, wide QRS complexes, a heart rate of 58, and lethargy. Which order or prescription should the nurse implement first? So the key term here is high potassium with wide QRS complexes. That key term indicates dysrhythmias. So just think, you have to give calcium gluconate first to glue down those crazy heart muscles and prevent the progression into those deadly heart dysrhythmias. So option number 4, IV calcium gluconate, because the key term was about dysrhythmias and high potassium. Now, question number 2, end-stage renal disease with a potassium of 7.2, a BUN of 35, creatinine of 38, and urinary output of 300 mLs in 24 hours. Which order is priority? So this question says high potassium, right? But nothing about ECG dysrhythmias, or basically heart dysrhythmias. So we need to lower that potassium first with insulin, which puts sugar and potassium into the cell. So option number 1, IV regular insulin and 50% dextrose. Yes, we give this first. Not loop diuretics and not dialysis. This is used later. And definitely not option number 4, the vacation time, even though it's pretty tempting. Now, as far as nursing interventions, generally we check daily weights at the same time every single day. So the key number to know is 1 kilogram equals 1 liter of fluid retained. So we must report any type of fluid retention to the HCP immediately, because this can lead to fluid volume overload and hypertension crisis. Now, we also avoid the top drugs that can cause kidney injury, like NSAIDs as mentioned before. So just think N in NSAIDs is N for not good for the entire body. We also avoid milk of magnesia, that antacid, as well as antibiotics, those vancomycin and gentamicin. Remember, it's a sin to give a mycin since it kills the kidneys. As well as CT contrast dye. Remember, contrast kills those kidneys. Just think of that contrast dye like thick cement in those delicate washer machines of the kidneys. Now, as far as procedures, as mentioned before, hemodialysis, which is the machine version of the kidney, is used to wash the blood, but only used for a number of years until a kidney transplant is available. Now, we cover both of these in their own separate videos. Alright guys, that wraps it up. Thanks so much for watching to the end. Now moving on to the practice questions for renal failure. So question number 1. The nurse is caring for a client with chronic kidney disease. The nurse understands that chronic kidney disease could contribute to which abnormal values? Select all that apply, our favorite questions, right? So pause the screen and try your best to answer this question in about 60 seconds or less. All right, let's break this question down, following the question breakdown strategy. So number 1, first look at the key terms in the question. CKD, or that chronic kidney disease, and abnormal values. So again, think of a few things you know about those key terms before looking at the options. So for renal failure, the kidney washer machines are broken, right? So there's no way to filter the blood from excess electrolytes and waste. Mainly these lab values from the full video. And the kidneys make erythropoietin, which tells the bone marrow to make more blood. So naturally, we'll see a low hemoglobin level. So let's look at the options now. Option number 1, potassium of 5.9. Yes, this is correct. Normal potassium is between 3.5 and 5.0. So 5.9 is way over. The client will have potential cardiac dysrhythmias, since potassium pumps the heart. Now option 2, a phosphorus of 2.0. No, this is incorrect. This is technically low phosphorus. We would expect high phosphorus, as normal phosphorus is 3.0 to 4.5. So 2.0 is way too low. Now option 3, a pH of 7.45. No, this is incorrect, but it's very tricky here. So listen close. This is high pH, indicating an alkalotic or base state. Now, clients with renal failure are likely to go into acidosis, a pH below 7.35, due to the retention of hydrogen ions, because the body cannot urinate out all that hydrogen ions inside the urine because they have broken kidneys. Now, option 4 and 5 are correct. So a hemoglobin of 9.2. This is way too low. Normal hemoglobin is above 12. Remember, the kidneys create erythropoietin, which tells the bone marrow to make blood. So naturally, hemoglobin will be low here when we have broken kidneys in renal failure. Now, option 5, creatinine of 2.3. Yes, the most critical kidney lab here. So remember the C's. Creatinine is critical, so creatinine over 1.3 means bad kidney. 2.3 is way too much. Now, moving on to question 2. The nurse is caring for a client admitted for COPD exacerbation. The client's history of present illness reveals a history of congestive heart failure, that's CHF, a myocardial infarction 3 years ago, basically that heart attack, with 2 stents placed, chronic renal failure, and hypertension. So based on these findings, the nurse recognizes that which of the following contributes to anemia. So pause the screen and try your best to answer this question in about 60 seconds or less. All right, let's break it down, following the question breakdown strategy. So number 1, we first look at the key terms in the question. So remember, the question's asking which contributes to anemia. Don't get lost in the sauce with all these big long names and this big history here. Now, secondly, think of a few things you know about anemia. Remember, anemia is that low blood level, namely low hemoglobin. So let's unpack it a little bit. Which leads to low hemoglobin? Is it COPD? Well, no, remember, COPD is a lung issue. What about CHF, that heart failure? This results in heavy fluid inside the body. So it's not going to lead to low hemoglobin. How about an MI, the myocardial infarction? Well, that's a heart attack. Remember, MI, the heart muscles die. So no anemia there. What about chronic renal failure? So remember, kidneys make erythropoietin, which tells the bone marrow to make blood. Naturally, there's going to be low hemoglobin with broken kidneys in renal failure. So in this case, option A would be the most correct. Question number 3. What is the pathophysiology of acute kidney injury in clients with congestive heart failure? So once again, pause the screen and try your best to answer this question. Okay, let's break it down, following the question breakdown strategy. So number 1, we always look at the key terms in the question first. Pathophysiology of acute kidney injury and clients with CHF, that congestive heart failure. Now, second, think of a few things you know about those key terms. So remember, acute kidney injury, also called acute renal failure, and heart failure. The heart has failed to pump oxygen-rich blood out to the body with decreased cardiac output. And this causes a pre-renal issue, meaning less blood flow going to the kidneys. Now, let's look at the options here. So option A, decreased renal perfusion. Yes, this is the most correct because remember, the heart has failed, so there's less cardiac output, meaning that there's less oxygen-rich blood going out of the heart, resulting in decreased perfusion or oxygen to the kidneys. Now, option B, C, and D are incorrect, and here's why. So option B, nephrotic medications, no, there's no indication or evidence that the kidney toxic drugs have been given in this question. And option C, infections. Once again, look at the question here. There's no indication of infection, and heart failure typically doesn't have any infection as a root cause. And option D is also incorrect. Contrast dye. Once again, there's no words indicating the client has had a CT contrast or has been given dye. So remember, let the question help you. So option A would be the most correct. Lastly, question number 4. The nurse assessing a client with end-stage renal failure expects which manifestations? So once again, pause the screen and try your best. All right, let's break it down following the question breakdown strategy. Number 1, we first look at the key terms in the question. End-stage renal failure, the kidneys have failed. And now it's the end, right? So for manifestations, we're looking for those signs and symptoms. So number 2, think of a few things you know about those key terms, specifically the end stages of renal failure. Now option A, decreased GFR and hypertension. This is incorrect. This is more for all stages of chronic renal failure. Now option B, azothemia and acidosis. Yes, remember, azothemia is a condition that occurs when the kidneys have been severely damaged and can no longer get rid of that nitrogen waste from that urine, leading to this azothemia and hydrogen ions, which also come out in the urine. Basically, they build up inside the blood, pushing the body into this acidotic state. So option B would be the most correct. Now option C and D are incorrect. So for option C, hyperkalemia and hypercalcemia. Now this is very close, but it's incorrect, as this can happen at any point during renal failure, as excess electrolytes build up inside the body and cannot get into the body. Now option D is incorrect because increased creatinine and decreased BUN. No, both creatinine and BUN should be high with kidney failure, and it's not specific enough for end-stage renal failure. So that's why option B would be the most correct here. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.